Hi, and welcome to Sientra's Tech News. Today, I am pleased to be able to bring to you the second episode where we'll dive a little bit deeper into techniques and technologies used to optimize outcomes for each patient. I'm pleased to be joined today by an expert panel of surgeons here in the US. We have 5 surgeons spanning the entire US. Out of Denver, Colorado is Dr. Andrew Wolfe. Welcome, Andrew. Thanks for being on the panel.
Thank you, my pleasure. Looking forward to a lively discussion with these esteemed surgeons.
And next on the panel from Westlake Village, California, we have Dr. Michael Schwartz. Thanks for being on, Mike.
Thanks, Blaine. I'm very excited to be here and glad to join all these great gentlemen to have this discussion today.
Great. And next out of Scottsdale, Arizona, we have the Dr. Steven Sigalove.
Thanks, Blaine. Super happy and excited to be here. All-star panel. It's going to be a great discussion today.
Yeah, thanks for being on. And out of Dallas, Texas, we have the Dr. Bill Adams.
Thanks, Blaine. Should be full throttle. It'll be a lot of fun.
And finally on our panel today is Dr. Troy Pittman from Washington, D.C. Thanks for joining us, Troy.
Thanks for having me. It's good to see everyone.
Great. Well, as we've started these in the past, first we'll start with a little bit of presentation to set up the discussion. And for that, we have Dr. Mike Schwartz. We'll discuss kind of the lessons and evolution of techniques and technologies as it relates to positional stability of implants. Thank you very much, Dr. Schwartz, for presenting.
Hello, everyone. Thanks for being with us today. What I'd like to do is provide you with some general information about breast implant history and some things that we're going to discuss today to lead into this amazing panel discussion. So first, let's talk about the history of implants in the US. As most of you know, pre-1992, the implants that were primarily used in the US were round smooth silicone and saline devices. These obviously were very popular and very different than the rest of the world, who also was using more textured devices. In 1992, when the implant moratorium came about, the US surgeons that still used implants chose predominantly smooth saline implants. In the US, textured round and shaped devices were developed at this time, and we quickly learned that there was a high failure rate. This was due to the lack of cohesivity of the saline in the implant shell and the shell-to-shell interaction, which led to fold flaws and deflation. And these devices quickly lost favor. In 2006, silicone was reapproved by the FDA in the United States, and surgeons who had become used to using round smooth devices with saline stayed with round smooth devices with silicone in the US, exclusively almost all smooth. This led to certain issues with implant size, position, long-term stability, but this was accepted around the country. In 2012, the FDA first approved the Sientra portfolio of round and shaped devices, including their textured round and textured anatomic devices. And this became a new phase in the world of breast augmentation. And many people led a more algorithmic approach to placing implants, implant planning, implant technique, and surgery, which has led to a significantly improved result, safety, and outcome for patients having breast augmentation. After that, in 2013, both Mentor and Allergan had their shaped and textured devices approved in the United States. And this subsequently followed on with 2019, where after years of data starting to show some problems that most surgeons weren't aware of, this led to the BioCell recall worldwide, and then now into the ALCL quote-unquote crisis that we are all experiencing. What I'd like to do is take some time to go through what I think are the benefits that have been discussed about textured implants. Obviously, not everybody agrees with all of this, but there's certainly been great data that's been supported by research from both surgeons and implant manufacturers for some of these points. Textured implants have shown to produce a decrease in capsular contracture. We're very certain that these devices give us a much better long-term positional stability, especially in patients with difficult anatomy. There is a decreased rupture rate in this newer 5th generation silicone gel implants, which relates both to the quality of the gel and the interaction of the gel and shell. Many surgeons report that textured and shaped implants can give a more natural shape during breast augmentation in properly selected patients. And of course, these implants with their differing base diameters, shapes, projections, firmness and softness of gel are much more helpful in correcting chest and breast asymmetries and deformities. Some of the negative things that are purported with textured implants are also important to discuss. Textured implants are slightly more palpable with a thicker shell and potentially firmer gel. They can be more difficult to place, but studies have shown that with proper technique, they're actually better positioned and have more long-term stability. Textured implants definitely have a difference in seromas, and although this occurs more in some texture than others, any device can have this. And of course, it's important to mention that once you detect a seroma or suspect a seroma in one of your patients, that needs to be addressed properly to rule out ALCL. Textured implants may or may not have a more natural shape. This has remained controversial, as many surgeons still feel that any device can provide a natural result in their hands. ALCL has become a big issue in the current time, but there's really an important difference between all devices. Not all textures are created equal, and I think it's important for everyone to be acutely aware of this. There are very different risks and results between different devices and different textured surfaces. Most importantly, it's important to note that the textures that have been associated with increased risk of seroma, increased risk of ALCL, that being biocell and polyurethane, have now been taken off the market. So what are the lessons that we've learned from textured implants? First of all, we've learned that device selection is important. There are different shapes, different gel cohesivities, different gel fills, and all of these can be used to obtain an optimal result. Surgical evaluation, dimensional analysis with respect to the soft tissue envelope, anatomy, chest wall, have all become much more important in obtaining an optimal result with long-term stability and minimizing complications. Surgical technique has evolved to a much higher level. The dissection of the pocket, pocket irrigation, techniques for closure and stability all become much more important and much better documented during this time. Other techniques that have evolved during this time that are also important are the use of other means of creating pocket stability and support. And these are important as we transition back to more frequent use of smooth implants. This includes suture fixation, use of surgical scaffolds, and the use of dermis in our primary and secondary cases. Adjunctive procedures help us get an optimal result, and these have come to the forefront. This includes fat grafting and capsulorrhaphy, among others. And finally, there are many lessons from reconstruction that's evolved in the most recent years, including prepectoral reconstruction, all of which focus on creating inferior and lateral support, which actually gives even more upper pole fullness. I hope that this gives you some information that you can use as we listen to the group's discussion. Once again, I'm really glad that you're here with us today for this webinar, and I hope I've given you the basis for some things to think about going through the webinar, coming back into practice, and trying to obtain the best results you can with breast augmentation moving forward. Thank you.
Thank you, Dr. Schwartz, for your presentation. I think you brought up a lot of critical topics in terms of better outcomes, certainly as it relates to the world of smooth round implants we're in now. But first from the panel, I'd love to get everyone's opinion on that of evolution he talked about. Are you still using texture, or is there still an indication for texture given all of the things that we've gone through? Where do you use it and where do you not use it? Let's start with you, Dr. Wolfe in Colorado.
So it's been a similar evolution. I started smooth. I trained during the tail end of the moratorium, and so came out with smooth saline, got into silicone, and then embraced texture pretty wholeheartedly. And then in 15, 16, when it started becoming apparent that there were some concerns with that in terms of ALCL, switched over to smooth, and my technique's been evolving a little bit. So I'm now pretty much almost entirely smooth.
Great, thanks for that. Steve Sigalove, what are your thoughts?
Thanks, Blaine. I am a huge believer in textured devices. Unfortunately, given the climate, the majority of my practice is in fact smooth round. I still, however, will use a textured device in the right patient after a long discussion, obviously, on risks and benefits. But there are still some very few patients who I think will benefit more. And I think that the success of their surgery sometimes actually will depend on the device that we choose.
Yeah, Blaine, I think there's a lot of misnomers about, just implants in general. Personally, I think texture is certainly a choice. I still use some textured implants. I've never been a big believer in a lot of the things that have been claimed about texture. And I think if you look internationally, a lot of people use texture for kind of the wrong reasons that aren't really scientifically validated. But despite that, I think for the vast majority of patients, you can get excellent results with any implant, whether it's a textured or a smooth implant. I tend to use smooth implants and round, and I've always done that, and I use texture, obviously, in an anatomic implant when I'm using that device.
Yeah, great thoughts, Dr. Adams. And how about you, Dr. Pittman?
Well, for me, really, there are three groups of people that I still think texture is beneficial in. Women with recurrent capsular contracture, women with chest wall deformities, or women who really have wide chest walls or very narrow chest walls, where using a round device is either going to make the implant sit way too high in a shorter torso, or the right implant is going to be way too wide in a narrow torso. Like Steve was saying, I think having a real discussion with the patient about the risks and benefits and what you're trying to accomplish and why the textured implant is important is a paramount to the whole discussion.
Great, also great points. And actually, I love that you talked about specific device choice for each individual patient based on their width. Let's dig a little bit deeper into that kind of a topic. How about actual device size choice in terms of total volume, given the tissue that the patient has? Obviously, you can't do the same thing every time, but how is that going to change, how long-term of a result you get in terms of positional stability? If you're putting in a really, really large implant because the patient wants a really large implant, what things are you doing to control for that, or what things are you doing to consult with the patient to get a more sensible result? Dr. Schwartz, what are your thoughts?
For me, I think the most important thing is talking about implant choice. When I speak to my patients in a consult, everything is about which is the appropriate implant for them and how do we pick that. So all of those things that the other presenters have mentioned are important. I want to talk about positional stability. I want to talk about anatomy. I want to talk about volume and long-term results without complications. So every patient gets a different device, and that's where the texture comes in for me, is in those patients with the difficult anatomy that Dr. Pittman mentioned so well, and then for the secondary capsular contracture patients. And I do agree with Bill that most patients can have a great augmentation with almost any device, specifically around smooth device. And to me, the places where that's difficult are chest wall anatomy and soft tissue coverage. That's where shape and texture still works for me.
I tell patients all the time, look, the key to getting a good result is picking the right implant. It doesn't matter who your surgeon is or how good they are. If it's the wrong implant perfectly placed is still not going to be an acceptable outcome for most people. And so picking the device is important. The challenge is if you have somebody who's either resistant to texture, or for whatever reason doesn't want it, I try to explain that we can use texture and it's going to make my life easier and ultimately your life easier. If I'm using smooth, we're going to have to operate our way around the limitations of that implant and your anatomy. So it may mean additional operations down the road. It may mean additional techniques or devices used during that round smooth operation.
I look at every breast augmentation or revisionary breast surgery truly as a customizable procedure, which is very specific and unique to this specific patient. And so by using the patient's anatomy and the theories of proportionality and using biodimensional analysis to evaluate our patients, we're really choosing the appropriate devices for these patients. And so the days of shoving a massive implant into a very tiny person are over, at least for advanced surgeons. I think there's a lot of kind of not so advanced surgeons that still do that, but we see the side effects of that, a year or two later. So I think that we have to treat every patient differently and truly customize the surgery and therefore the device for the specific patient.
So one of the other things, Blaine, that I was going to mention was the fact that one of the huge benefits coming out of textured and more cohesive gel implants is that we now have so many choices. So we're not just talking about size, and we're not just talking about, is this round implant going to look best for you or high profile, but we have different consistencies of gel, and we have different dimensions of the implants to fit on different chest walls. And all of that's kind of evolved in the last 5 to 10 years to give us much better choices for what we can do with each patient and still make it appropriate for their size.
Yeah, Blaine, I think one of the last tech news is we talked a lot about different technologies, and I think that's clearly important, but I also think the bigger picture is probably more important. So we talk about the process, say, of breast augmentation, And that's just that's about breast augmentation, but there's the high level of breast surgery in general. And I think it's very different than what was done 25 years ago. And, starting about 20 years ago, we started to learn about this. And it's not just one thing. You can't just pick the right implant, but it has to be the right implant, the right size for that patient. The patient needs to be educated. The surgery needs to be done well. The patient needs to be managed appropriately post-operatively. And if you do all of that, then the outcomes can be exceptional. But it's not one thing. And I think that's what we've learned over the years.
Don't you guys also agree that from our experience with textured implants, we really became, I think, better surgeons technically, and our dissection of our pockets with our smooth implants resembles that of our pockets with textured implants. And we no longer just making these massive pockets blindly. We're being very precise in our dissection. And I think that gives us better long-term outcomes.
Absolutely. And that's what when I talk about kind of the highest level of breast surgery, that's what it was 30, 35 years ago. Everybody made these huge pockets. It was like considered to be the intern's procedure. And so what we learned is, number one, that didn't work very well. Number two, patient outcomes suffered. And number three, there was something different out there that produced results that people had never seen before. So, I actually was medical director for Mentor's actually CPG study, which was their anatomic implant study. And what was interesting is we had surgeons, all were very good, but they had never, used some of these techniques that we all kind of talk about now being kind of mainstream. These are things like, hey, you actually measure the patient and you actually pick an implant that fits the breast, and you actually do the actual dissection to fit the dimensions of the implant that you selected. And it was like, wow, these are like novel concepts. And then all of a sudden people started doing these things and they said, wow, look, my patients are doing a lot better, my outcomes are better. And so that's how I think it evolved. I agree totally, Steve. It's very dependent on some of these techniques that have evolved over the past 20 years.
Bill brought up the biggest key to me, which is over the last 10 years or so, most surgeons who do high-level breast surgery do a much different analysis, a much different technique, planning and execution of their surgery. And if there's anything to be learned from textured implants, that might be the most important thing.
So much of what I learned initially about pocket dissection was in reconstruction patients, where you really had, where I was using a lot of shaped implants. And so the pocket dissection was everything to really keep those shaped implants in place and to keep them from rotating, and being able to plan that reconstruction, looking at what the ideal breast base width was going to be for that patient when her breast mound was completely gone. And all of those reconstructive principles, I now apply all the time to cosmetic patients, but I think pocket dissection is key in so many of these things, particularly when you have to use a smooth implant and you don't want that implant moving around the pocket.
Yeah, Troy, I think that's a good point. And, if you look at recon, it actually evolved too, because I remember back in my residency, we were taught to widely overexpand the breast, and that evolved, and people just, people that do a lot of it now, I don't do that much anymore, but you don't do that, and it's more precise, and it's more like just a precise, cosmetic breast procedure.
Shaped implants in particular are really unforgiving. And so partly texture, but I think more than anything, it's the anatomic nature of an implant, where if you over dissect or under dissect and the implant's folding on itself, you've got really high level implants that will behave very well, but if you don't get that pocket just right, then they underperform.
The continuation of all of this topic is that the techniques are the most important, and then the device follows. And when people try to choose a single device and use it across the board, I think that's where we get issues. Let's go back to this evolution between recon and augmentation, because I think it's super important. What you were just talking about, this evolution of overexpansion, and now we're really doing the final expansion, is the implant exchange. Similarly, in recon, we've moved from all submuscular to avoid things to now pre-pec. In augmentation, I think there's a lot of lessons to be learned there too, because if you do the pre-pec or in this subglandular placement, you are severing some of the vascularity, but as long as you don't put an overly large implant, that it probably does great, and you just have to make sure that you're contouring it and supporting it. What are your thoughts on that? How that's evolved with you, Dr. Sigalove? We'll start with you.
Yeah, for me, I really come full circle. We've seen kind of the evolution of soft tissue support and breast reconstruction since the 1970s, from subcutaneous to full muscle to partial muscle to dual plane with ADM, and finally back to pre-pec now. And we've gotten better over the years, and our aesthetic results are super, obviously way better than they used to be in the 1970s. Same thing for aesthetics. My pre-pectoral experience, which I started in 2013, kind of led me to kind of thinking that we could probably do similar operations in specific patients in the aesthetic world in kind of that subfascial space. So in my breast practice, I do a lot of work in the subfascial plane, whether it be revisionary or primary, but I'm always supporting it with a bioresorbable scaffold to ensure lower pulse support as well as upper pulse stability. So it minimizes rippling and wrinkling. I'm typically not having to fat graft nearly the same amount as when I use some of the other products, particularly ADMs. And it's really been fantastic for both my aesthetic and my reconstructive practice.
Great. Any comments on the same topic, Dr. Pittman?
Well, that's where, I think device selection really comes in. And so, we know that upper pole rippling in pre-pack that we were always trying to cover with fat grafting, so much of that was lack of inferior lateral support of the implant. And being able to have a device that certainly is more cohesive, that's not going to move, and then having the scaffolding to support the implant. For me, I don't really do much fat grafting at all in pre-pec patients because I really have that implant supported and rippling is not an issue.
And how about you, Dr. Wolfe? Pre-pec versus submuscular, what are the indications?
It's interesting. I do the significant majority of my cosmetic augmentations in a dual plane fashion, but watching the evolution of the reconstruction world and what the results they're getting with no animation deformity, less chest wall morbidity. I'm wondering over time, are we going to figure out a way that we can do that? And obviously, certain surgeons are. I'm probably a little old school and still doing most things with muscular coverage, but I think there's certainly a role for especially subfascial, but even the subglandular. The challenge, I think, is now that we're doing less texture. I used to prefer texture when I was above the muscle just for capsule contracture and stability. And so I'm struggling a little bit with a shift to smooth implants in patients who want an implant placed above the muscle. So maybe that bioresorbable mesh is the answer there, that scaffold.
Yeah, and there's cost differences too. It's easier for that evolution to happen in recon once the federal government required coverage for reconstruction, that all these scaffolds and things could develop into that continuum. So now when we move over to cosmetic, which is already a very price-driven market, it's tougher to bring that to the mass market, but certainly something worth considering.
I was going to add, Blaine, that one of the things that allows me to kind of feel much more comfortable doing these subfascial revisions and subfascial augmentations is these Sientra implants and the cohesivity of the Sientra implants, yet the soft nature of them. So in my subfascial augmentations and revisions, I'm using kind of the HSC Plus, which has given me a whole new kind of advantage over some of the more firm and more kind of hardier, higher cohesivity implants from the other companies. So when I started using these Sientra HSC Pluses, it was like a game changer for my subfascial world. So, thanks for putting out these implants, because my patients love how soft they are, and yet they're completely durable and sturdy. And, that gel shell interaction makes them just a better device, particularly when we are in that subfascial plane.
I think to that point though, is patients ask all the time, why are we offering pre-pectoral reconstruction when we didn't before? And every time, Steve, I know when we're out there and we're talking about recon and pre-pec recon, there's always someone in the audience who says, okay, so do you do your breast dogs now all subglandular? And the answer, I think, is the same for both of those questions. Is we're able to offer pre-pec breast reconstruction now because we have better materials to work with. And I think that when we look at all of the studies that were done to show that there was an increased rate of capsular contracture in subglandular implants are all old studies. And we don't really have a lot of new studies with the new technology to look and see whether these new implants with less gel bleed and less overall wrinkling and rupture, I think we're going to see the data be completely different, that we're not going to see these really high rates of capsular contracture with subglandular implants.
And if you look at the quality of the mastectomy skin flaps, it's night and day in most breast surgeons compared to what it was 10 years ago. The materials are better, we've got better products, and we're using 14 points in not only aesthetic surgery, but we're applying that to reconstructive breast surgery as well. And I think we're doing this kind of shotgun approach, taking care of all angles. And because of that, our numbers are just so much better than the data that you're referring to. I totally agree with you. I mean, our early prepectoral experience, our capsular contracture rates were just amazing, and I think it's a testament to all these improvements in what we're able to provide patients with.
Yeah, who the people that are actually asking the most questions about prepectoral breast recon is the FDA, and so it's really important. Like Steve, what you're doing, and Alan Gabriel and Roy DeVita, publishing on that and really educating people about. It was kind of. I'm kind of beyond that. I don't do any recon anymore, but it's very interesting. I think it's very compelling what you guys have presented and what you're saying, because you're seeing that it is maybe a superior alternative to what we were doing, over the past 20 years. So I think it's going to be really important to have that data and continue producing it. And the other thing I was going to say is I think prepectoral breast recon is a little different in the argument, and I actually agree with what Troy said. I think technique is that's the reason we saw issues with capsular contractures. And it's the same thing we were saying about texture. People are using these older techniques when these studies were done, and nothing like we're doing now. So I think if you use the same technique with the same devices, you're probably going to have the same outcome with regard to capsular contracture. But the one thing I'll say, subglandular position with a breast augmentation, you're changing the blood supply to that breast forever. And so particularly people that have breast tissue, they're going to be coming back at some point, may need to have breast lifts. And sometimes that can limit our ability to treat those patients at some point. Whereas in the breast recon patients, they don't have any breast tissue. That's really not an issue. And so again, I think pre-pec it's not really an issue to do a pre-pec breast recon.
Thank you guys. That is excellent discussion. Let's go back to the idea of fixation. So again, you're now using mostly smooth, whether you're doing submuscular or subglandular. What are you doing differently than maybe you were doing pre-textured to really ensure that long-term stability of especially the inframammary fold? Dr. Wolfe, I've seen you in the OR do a little bit different stuff with your suture at the fold. Do you want to talk a little bit about that?
Yeah, and so one of the challenges of fixation and stabilizing the inframammary fold is that there's been a switch towards smooth implants and then a shift towards an inframammary approach as opposed to a periareal approach based on the capsular contracture risk, which I think are pretty unequivocally superior in the fold. And so you are by definition punching a hole through the really central support for that implant. And so when you come back, you've got to, I think, be very conservative on the way in and maintaining the attachments at the fold and leave a good cuff that you can fixate the gland to. And on the way out, make sure that you nail it down. And I use a 2.0 PDS on everybody, smooth implants, textured implants, to really nail that fold down. And that's right. We all know that's a stitch you should be able to lift the patient off the table with. And that was one of the bigger things. I switched from a monochrome fixation back in 15-16 with textured implants over to PDS, and that seems to work well. And I've had a lot fewer challenges with inferior malposition.
Great. And let me just follow up on that really quick, as you talked about the technique of changing, kind of maintaining that cuff. Are you're going through the skin, you're starting shallow, and then you get past that cuff and then you go deep, or how are you achieving that?
Yeah, it's so you're not, in a lot of these patients, you're making the incision maybe a little bit below the native inframammary fold. And if you go deep and then superiorly, you're going to blow through all those attachments. And so it's a dissection cephalad and then deep. So a real effort to maintain that anatomic structure that is the fold.
Right, I'd agree. I think one of the lessons I've learned through textured is stabilizing the inframammary fold, and PDS is also the suture that I use. In this transition back to smooth, one of the big things that I've worked hard to do is, in the primary case, If it's a larger implant or a chest wall that's really lateralized, I'm going to use scaffold to support that fold, even in elective primary aug. And if it's a secondary case, I'm going to use that PDS to do my capsule. And then in some patients, when that capsule is thin and flimsy, I'm going to use the scaffold as well. And those patients have to hear all that coming into surgery and know that that's part of the choice they're making for their surgical goals.
You know, it's funny because when I trained with Scott Spear, and Spear did not fixate anything at the fold. I mean, I went through my entire fellowship and did hundreds of breast augmentations and didn't put a single stitch at the fold. And I thought that was the way it needed to be. And it wasn't really until I went to Sweden with Rehnquist and saw his, I think he calls it the Lucky 8 stitch, and saw him really tether down that fold to keep those implants from bottoming out, that I started doing that. And I'm lucky enough now in DC, I see a lot of Scott's patients who need revisions, and a lot of those patients are bottoming out. But it wasn't anything that we ever really talked about 10 years ago, of this fixating the fold. I mean, don't you feel like this is something new that we've learned, or have you guys been doing this all along?
So I could tell you, when I went to visit Charles 10 years ago, I saw that stitch as well. And quite honestly, it put a little fear into me to put that giant needle right next to the implant. And when I came back and started using textured implants, I never did it. And I don't honestly know that I believe that that makes a big difference in most of the patients. On the other hand, I think that using PDS to reclose scarpous fascia at the bottom of your incision is essential, because in the past I'd always used monocryl, and that's going to be gone in a few weeks. It has no strength, and the pocket doesn't have stability at that point. So I do think you need something in the fold, especially because we're going through the inframammary fold, as Dr. Wolfe said, but I don't know that that big stitch is always safest might be.
I mean, I think probably the person that I think first kind of publicized this was Paradin, and that was 25 years ago. It was his 3-point suture, and I think a lot of people have done different things. We actually published a paper on inframammary fold fixation. There's some patients that are at risk for inferior malposition, so I kind of agreeing with both viewpoints, because I don't think everybody needs that stitch. But if you have somebody that has element of constricted lower pole breast, nulliparous patients, firm glandular breast tissue, relatively short inframammary folds, anybody you've lowered the inframammary fold in, no matter how precise you do that dissection, you're going to potentially have an occult weakening of that area. And so just with gravity and the implant, it can expand and you can get a little inferior malposition. So those are the patients I tend to put that 3-point inframammary fold fixation suture in. And I think it's effective, but I don't do it in everybody.
I went to Sweden as well, and I came home with the Lucky 8 stitch, and I tried it for about 3 weeks, and I think I turned the Lucky 8 into probably like a Lucky 4 stitch maybe. And so I kind of did a permutation of that, where, just like Mike says, I think scarpas to chest wall is key. And so PDS, the same thing. And I think that is critical, at least for my dual planes. And so I'll do that minimally scarpas, and sometimes I'll add like the permutation of the Charles stitch when I'm really worried about it. But for my subfascial augmentations, primaries, I use P4HB scaffold in every single one of those to stabilize the fold. So I'm literally giving them lower pole support and IMF support, but at the same time, it actually stabilizes the upper pole as well, kind of giving a complete control of the overall pocket. But it's all about control, and I do believe that it starts at the fold.
Steve, in a primary aug, how do you justify and discuss the extra cost of using the scaffold with the patient?
I give the patient basically the discussion on dual plane and the discussion on subfascial, and I talk about the pros and cons of each. And I talk about one of the cons of the subfascial is the fact that it's going to cost them more. But in certain patients, it may be beneficial, the extra cost of the mesh and the extra OR time, because they're not under the muscle, they don't have to deal with animation. Maybe they want to do, they're bodybuilders or bench pressers or Pilates instructors. And so for those very specific patients, some of them, or actually many of them, actually feel that the extra cost of the product is worth it for them. And once again, I don't do it in every single case. It's patient to patient, but I have a discussion about both types of surgeries, And in certain patients, I might recommend maybe the subfascial or maybe the dual plane, but along with it comes the extra cost. And so they know the costs up front. They're given kind of a price range when they make the phone call to make the consult. So it's never a surprise to them when I'm talking to them.
You and Robert probably not attracting a really price conscious patient population, right? So there's different practices have different flavors, and you guys are a premium practice. That's probably a harder sell for somebody who's trying to grow volume, and that kind of cost can be prohibitive for somebody who's got a patient who's really cost sensitive.
Yeah, I agree. 100%. It's not the standard middle of the road breast augmentation, but for the right patient, I think you can make a decent argument for the extra cost, given what kind of the benefits can be when you're not cutting the pec muscle on those particular patients. But you're right. It's not for every patient, and it's certainly not for every patient population. There's only going to be certain people who are going to be willing to pay the extra. And I'm actually quite surprised, because when I actually present it to the patients, a lot of them are like, "Oh my gosh, that sounds amazing. I'll do it." So I'm not getting a ton of fighting on the extra cost, to be honest.
I think what we've all agreed on tonight is, breast augmentation is a nuanced operation. Careful pocket dissection, careful device selection, patient education. These are all things that are innate to us and we're all doing, but not everyone is. And I think when you look at, we talk about importance of board certification, these kinds of conversations that we're having are not necessarily intuitive to a lot of people out there who are performing these operations and who are having higher complication rates.
I think that, to me, there's three lessons here, and Troy basically said it, which is number one, limited pocket dissection. Number two, dimensional planning. That operation should happen before you get to the operating room in your mind, so you know what you're going to do. And number three, that you have to respect the inframammary fold, and you have to know that if you don't, that's where the problems are going to come from. I think those are the key points we've really touched on. It's technique. Devices matter, technique.
Dr. Wolfe, final thoughts.
I think we've got an unprecedented array of different, very high quality implants that we can choose from. We've got different meshes and scaffolds and ADMs to choose from. We've got different planes. It's become a very complex operation. And so it behooves every surgeon who's doing this with any kind of frequency to be facile with all of these different choices and be able to offer the entire toolbox to your patients, because you've got to really tailor that approach to the individual anatomy and desires of that person.
Great, thank you for that. And Steve?
I think it all boils down to educating your patients, being upfront with them, respecting their anatomy, respecting the proportionality of what you're trying to achieve, and knowing how to take care of problems when they arise. And I think if we do that, we're going to be on the straight and narrow.
Great. And final word, Dr. Adams, thanks for the studio.
Well, I think it's been a great discussion. I've learned a lot from these colleagues of mine. And, I was just thinking when you all were talking, it boils down to there's a lot of choices now. That's great. It's great to have a lot of choices, and it's great for surgeons, but it's also great for patients. So I think now is the era that we are moving into, where we have better everything, better thought process, better devices, and I think at the end that's going to be better for our patients. So that's probably the most important thing. So I've enjoyed it and look forward to many more.
All right, well, I thank you all for spending the time with us today and bringing your great experience to others. Hopefully through this format, we'll be able to increase the learning curve for all surgeons, but certainly ones that are coming out of training and trying to be the best board certified plastic surgeon they can be. So thanks for joining us today on Sientra Tech News. Bye, guys.